Hello everyone. Today our lecture will be on neurodevelopmental disorders and intellectual disorder that comes under the branch of neurodevelopmental disorder. I will be introducing it to what neurodevelopmental disorder is and also explaining it what comes under it and how it can be further understood. So, what exactly are neurodevelopmental disorders? They are a group of conditions which have an onset in the developmental period. They usually develop early on during the childhood process. They develop in the early childhood before the child enters grade school. So basically, before a child enters school and goes to kindergarten or grade 1 or 2, that is the early developmental period of a child. So that is when these kind of disorders actually developed. They are characterized by developmental deficits, impairment of personal, social, academic, or occupational functioning. They cannot perform in their personal functioning as compared to others around them. They cannot perform up to the mark in the social or academic um, side or these areas in their life in the in the way that children their age actually do perform in. So there are a range of different developmental deficits that are present. It actually varies from very specific limitations of learning or control of executive functions to global impairments of social skills or intelligence. So there are two things that we have here. It can be very limited to very specific limitations of learning. For example, a child may not be able to write properly, or they may not be able to speak properly, or it can have global impairments of social skills or intelligence. The intelligence of a child may be hindered, or how they behave socially. They frequently co-occur. For example, individuals with autism spectrum disorder often have intellectual disability. Many children with attention deficit hyperactive disorder or ADHD also have specific learning disorder. So the developmental deficits often co-occur with one thing or the other. So as I've mentioned before, autism spectrum disorder often has a collision with intellectual disability, how the person perceives things, the intelligence that comes in. For some disorders, the clinical presentation includes symptoms of excess as well as deficits and delays in achieving expected milestones. So, the presentation of how milestones are achieved. For example, by the age of 1 year old, has the child started speaking some words? Has a child started speaking some sentences or some full sentences when he's 2 years of age? Has he started crawling when he was 6 months old? So these are some expected milestones where there are some delays or excess where it is important to measure these. So these are the disorders that actually fall in the category of neurodevelopmental disorders. These actually will be discussed one by one in all our presentations, in all our lectures. So this will all be categorized and discussed. Intellectual disability, also known as intellectual developmental disorder, is characterized by deficits in general mental abilities such as reasoning, problem solving, planning, abstract thinking, judgment, academic learning, and learning from experience. The deficits result in impairments of adaptive functioning, such that the individual fails to meet standards of personal independence and social responsibility in one or more aspects of daily life, including communication, social participation, academic or occupational functioning, and personal independence at home or in community settings. The communication disorders include language disorder, speech sound disorder, social pragmatic communication disorder, and childhood onset fluency disorder known as stuttering. The first three disorders are characterized by deficits in the development and use of language, speech, and social communication, respectively. Childhood onset fluency disorder is characterized by disturbances of the normal fluency and motor production of speech, including repetitive sounds or syllables. Autism spectrum disorder is characterized by persistent deficits in social communication and social interaction across multiple contexts, including deficits in social reciprocity, nonverbal communication behaviors used for social interaction, and skills in developing, maintaining, and understanding relationships. In addition to the social communication deficits, the diagnosis of autism spectrum disorder requires the presence of restricted, repetitive patterns of behaviors, interests, or activities. Within the diagnosis of autism spectrum disorder, individual clinical characteristics are noted through the use of specifiers as well as specifiers that describe the autistic symptoms. ADHD is a neurodevelopmental disorder defined by impairing levels of inattention, disorganization, and or hyperactivity and impulsivity. Inattention and disorganization entail inability to stay on task, seeming not to listen, and losing materials at levels that are inconsistent with age or developmental level. Hyperactivity, impulsivity entails overactivity, fidgeting, inability to stay seated, intruding into other people's activities, and inability to wait. Symptoms that are excessive for age or developmental level. The neurodevelopmental motor disorders include developmental coordination disorder, stereotypic movement disorder, and tic disorders. Developmental coordination disorder is characterized by deficits in the acquisition, execution of coordinated motor skills and is manifested by clumsiness and slowness or inaccuracy of performance of motor skills that cause interference with the activities of daily living. Stereotypic movement disorder is diagnosed when an individual has repetitive, seemingly driven, and apparently purposeless motor behaviors such as hand flapping, body rocking, head banging, self biting, or hitting. Tic disorders are characterized by the presence of motor or verbal tics, which are sudden, rapid, recurrent, non-rhythmic, stereotyped motor movements or vocalization. And lastly, specific learning disorder, as the name implies, is diagnosed when there are specific deficits in an individual's ability to perceive or process information efficiently and accurately. This neurodevelopmental disorder first manifests during the years of formal schooling and is characterized by persistent and impairing difficulties with learning foundational academic skills in reading, writing, and or math. So this was a basic introduction to what these disorders are and what they are known as, what are their different characteristics. We will be starting with the So it is good to have knowledge of what we're going to be going into. So the first group of um, disorders that will be going towards is the intellectual disorder or the intellectual disability. Intellectual disability, intellectual developmental disorder. So we'll be starting with the diagnostic criteria. What is the diagnostic criteria? The diagnostic criteria is the list of symptoms or the criteria of symptoms that is essential, that is required for a healthcare practitioner to make a diagnosis to what is happening with the individual and how long it has been there. On the basis of these symptoms, the diagnosis is confirmed. Intellectual disability is a disorder with onset during the developmental period that includes both intellectual and adaptive functioning deficits in conceptual, social, and practical domain. The following three criteria must be met. A. Deficits in intellectual functioning such as reasoning, problem solving, planning, abstract thinking, judgment, academic learning, and learning from experience, confirmed by both clinical assessment and individualized standardized intelligence testing. There are different tests that are used for intelligent or intellectual development. So since we are only discussing what there is in the DSM, I will not go on towards the testing as that can be done in another course, since there are a lot of tests which can be covered in a lot of detail. B. Deficits in adaptive functioning that result in failure to meet developmental and socio-cultural standards for personal independence and social responsibility. Without ongoing support, the adaptive deficits limit functioning in one or more activities of daily life, such as communication, social participation, and independent living across multiple environments such as home, school, work, and community. And C. Onset of intellectual and adaptive deficits during the developmental period. So these, it is very important to know the developmental period is the period when the child is actually developing from age 3 or 4 onwards until the child joins grade school, kindergarten or grade 1. That will tell how a child is developing and if there is any developing issue or not. Now let's continue forward. So these are a few codes that are used. 317 F70, which is mild, 318.1 moderate, 318.2 severe, 318.1 severe, 318.2 profound. So these are basic specifiers that I'll be discussing ahead of how the diagnosis is actually given, of how a child is actually diagnosed, that the if the disorder is mild, if the disorder is moderate, if the disorder is actually more developed, and how it goes about. So let's start with talking about the mild level of severity for intellectual disability. So we have basic three domains: the conceptual domain of how the individual or how the child actually understands it, how they understand something; the social domain of how they react in a social setting; and the practical domain of how they react practically. Severity level mild. Conceptual domain. For preschool children, there may be no obvious conceptual differences. For school age children and adults, there are difficulties in learning academic skills involving reading, writing, arithmetic, time, or money, with support needed in one or more areas to meet age related expectations. So, over here, what we can derive is that in one or more areas where the child is not being able to meet the age related expectation, that and is having difficulty in doing that concept, that is where we can pick out a cue that the child may have this issue. In adults, abstract thinking is executive functioning such as planning, strategizing, priority setting, and cognitive flexibility, and short term memory, as well as functional use of academic skills, that is, reading, money management, are impaired. So, in adults, these are the basic things or the basic skills that are impaired. And when these are impaired, that is when we know that there is something that has an issue. There is a somewhat concrete approach to problems and solutions compared with age mates. Social domain. Compared with typically developing age mates, the individual is immature in social interactions. For example, there may be difficulty in accurately perceiving peers' social cues. Communication, conversation, and language are more concrete or immature than expected for age. So over here, for children, or it can come for adults also. Communication and interacting abilities are not up to the level, and they are um, difficult or immature for their age group. There may be difficulties regulating emotion and behavior in age appropriate fashion. These difficulties are noticed by peers in social situations. There is limited understanding of risk in social situations. Social judgment is immature for age, and the person is at risk for being manipulated by others. So, since there is a limited understanding of what is happening and how things can be done, there does come a difficulty. Practical domain. The individual may function age appropriately in personal care. Individuals need some support with complex daily living tasks in comparison to peers in adulthood. Supports typically involve grocery shopping, transportation, home and childcare organization, nutritious food preparation, and banking and money management. So, support in the practical domain, a cue that we can see for the mild level of severity is that whenever there is an issue coming, or there is some kind of barrier coming, or an area where they need help in doing these basic practical things, that is a cue that we can say that there is some kind of intellectual disability that is present. Recreational skills resemble those of age mates, although judgment related to well being and organization around recreation requires support. In adulthood, competitive employment is often seen in jobs that do not emphasize conceptual skills. Individuals generally need support to make healthcare decisions and legal decisions, and to learn to perform a skilled vocation competently. Support is typically needed to raise a family. So that this is where intellectual disability actually affects the practical domain of an individual and how it affects us. Let's come to the moderate severity level of the intellectual disability. We have the conceptual domain. All through development, the individual's conceptual skills lag markedly behind those of peers. For preschoolers, language and pre-academic skills develop slowly. For school age, so over here what we can say is that the individual's conceptual skills visibly lag behind those of peers. They cannot come to the level of peers. For preschoolers, pre-academic skills develop slowly. There are language barriers, language is not developed properly. For school age children, progress in reading, writing, mathematics, and understanding of time and money occurs slowly across the school years and is markedly limited compared with that of peers. So, for school children, basic concepts of reading, writing, maths, understanding of time comes slowly over the period of school years and is comparatively limited to that of the peers. For adults, academic skill development is typically at an elementary level, and support is required for all use of academic skills in work and personal life. Ongoing assistance on a daily basis is needed to complete conceptual tasks of day-to-day life, and others may take over responsibilities fully for the individual. Social domain. The individual shows marked differences from peers in social and communicative behavior across development. Spoken language is typically a primary tool for social communication, but is much less complex than that of peers. Capacity for relationship is evident in ties to family and friends, and the individual may have successful friendships across life and sometimes romantic relationships in adulthood. However, individuals may not perceive or interpret social cues accurately. Social judgment and decision making abilities are limited, and caretakers must assist the person with life decision. Friendships with typically developing peers are often affected by communication or social limitations. Significant social and communicative support is needed in work settings for success. So, these are the many areas in the social domain which are effective in the mild severity level, and they do need guidance there. Practical domain. The individual can care for personal needs involving eating, dressing, elimination, and hygiene as an adult, although an extended period of teaching and time is needed for the individual to become independent in these areas, and reminders may be needed. So so there may be basic things like taking care of personal needs, which can be learned through years of practice, and then it can be added to it. Similarly, participation in all household tasks can be achieved by adulthood, although an extended period of teaching is needed and ongoing support will typically occur for adult level performance. Independent employment in jobs that require limited conceptual and communication skills can be achieved, but considerable support from co-workers, supervisors, and others is needed to manage social expectations, job complexities, and ancillary responsibilities such as scheduling, transportation, health benefits, and money management. A variety of recreational skills can be developed. These typically require additional supports and learning opportunities over an extended period of time. Maladaptive behavior is present in significant minority and causes social problems. So let's come to the last part of it, which is the severe and profound part of the severity level. Uh, in the severe severity level, the conceptual domain, attainment of conceptual skills is limited. The individual generally has little understanding of written language or of concepts involving numbers, quantity, limited time, and money. Caretakers provide extensive support for problem solving throughout life. These individuals are impaired throughout their lives. Social domain. Spoken language is quite limited in terms of vocabulary and grammar. Speech may be single words or phrases and may be supplemented through argumentative means. Speech and communication are focused on the here and now within everyday events. Language is used for social communication more than for explicitation. Individuals understand simple speech and gestural communication. Relationships with family members and familiar others are a source of pleasure and help. So, spoken language is very limited in terms of language and grammar and vocabulary, and cues are not understood that well either. Practical domain. The individual requires support for all activities of daily living, including meals, dressing, bathing, and elimination. The individual requires supervision at all times. The individual cannot make responsible decisions regarding well being of self or others. In adulthood, participation in tasks at home, recreation, and work requires ongoing support and assistance. Skill acquisition in all domains requires long term teaching and ongoing support. Maladaptive behavior, including self injury, is present in a significant minority. So, these are all the practical challenges that a person with severe intellectual disability can face, and it is very important that the individual is helped throughout their life so that they can actually progress. Now, coming to the profound severity level, conceptual domain. The conceptual skills generally involves the physical world rather than the symbolic processes. The individual may use objects in goal-related, goal-directed fashion for self-care, work, and recreation. Certain visospatial skills such as matching and sorting based on physical characteristics may be acquired. However, co-occurring motor and sensory impairments may prevent functional use of objects. So, in the profound severity level, the conceptual skills are involved with the physical world. For example, the individual will use objects to cater to their symbolic processes. So, that is how an individual works in that process. The social domain, the individual has very limited understanding of symbolic communication in speech or gesture. He or she may understand some simple basic instructions or gestures. The individual expresses his or her own desires and emotions largely through non-verbal, non-symbolic communication. The individual enjoys relationships with well known family members, caretakers, and familiar others, and initiates and responds to social interaction through gestural and emotional cues. Co occurring sensory and physical impairments may prevent many social activities. Now, let's come towards the last practical domain of this part. The individual is dependent on others for all aspects of daily physical care, health, safety. Although he or she may be able to participate in some of these activities as well, the individual becomes so dependent on another person that they're not able to do these things themselves. Individuals without severe physical impairments may assist with some work tasks at home, like carrying dishes to the table. Simple actions with objects may be the basis of participation in some vocational activities with high levels of ongoing support. Recreational activities may involve, for example, enjoyment in listening to music, watching movies, going out for walks, or participating in water activities, all with the support of others. Co-occurring physical and sensory impairments are frequent barriers to participation in home, recreational, and vocational activities. Maladaptive behavior is present in significant minority. So these are all things that are adopted and that are there um, for a person or an individual um, with profound intellectual disabilities. Diagnostic features. So, what are the diagnostic features that are actually there? What do you mean by the diagnostic features? So the diagnostic features is a part of the DSM which actually gives you details on how to go about and explaining the diagnostic criteria. What are the symptoms that are there that needs to be diagnosed? The essential features of intellectual disability are are deficits in general mental abilities, which is criteria A, impairment in everyday adaptive functioning in comparison to an individual's age, gender, and socially cultural match peers, impairment in actually doing the daily day-to-day tasks that a peer of the same age group may be able to do but the individual is not able to do. That is criteria B. Onset is during the developmental period. This is criteria C. The diagnosis of intellectual ability is based on both clinical assessment and standardized testing of individual intellectual and adaptive functions. Criteria A refers to intellectual functions that involve reasoning, problem solving, planning, abstract thinking, judgment, learning from instruction and experience, and practical experience. Critical components include verbal comprehension, working memory, perceptual reasoning, quantitative reasoning, abstract thought, and cognitive efficacy. Intellectual functioning is typically measured with individually administered and psychometrically valid, comprehensive, culturally appropriate, psychometrically sound tests of intelligence. Now let's come to criteria B. Deficits in adaptive functioning refer to how well a person meets community standards of personal independence and social responsibility in comparison to others of similar age and socio-cultural background. Adaptive functioning involves adaptive reasoning in three domains: conceptual, practical, and social. The conceptual or academic domain involves competence in memory, language, reading, writing, math, reasoning, acquisition of practical knowledge, problem solving, and judgment in novel situations, among others. The social domain involves awareness of others' thoughts, feelings, and experiences, empathy, interpersonal social skills, friendship abilities, and social judgment, and among others. The practical domain involves learning and self-management across life settings, including personal care, job responsibilities, money management, recreation, self-management of behavior, and school and work task organization, among others. Criteria B is met Criteria B is met when at least one domain of adaptive functioning, cultural, conceptual, social, or practical, is sufficiently impaired that ongoing support is needed in order for the person to perform adequately in one or more life settings at school, work, at home, or in the community. To meet the diagnostic criteria for intellectual disability, the deficits in adaptive functioning must directly be related to the intellectual impairments described in criteria A. Criteria A, criteria C, onset during the developmental period refers to the recognition that intellectual and adaptive deficits are present during childhood and adolescence. Associated features supporting diagnosis. Intellectual disability is heterogeneous condition with multiple causes. There may be associated difficulties with social judgment, assessment of risk, self-management of behavior, emotions or interpersonal relationships, or motivation in school or work environment. Lack of communication skills may predispose to disruptive and aggressive behaviors. Gullibility is often a feature involving naivety in social situations and a tendency to being easily led by others. Gullibility is often a feature involving naivety in social situations and tendency to tend to be easily led by others. Gullibility and lack of awareness of risk may result in exploitation by others and possible victimization, fraud, unintentional criminal involvement, false confessions, and risk for physical and sexual abuse. These associated features can be important in criminal cases, including the Atkin type hearing involving the death penalty. Prevalence. What is the prevalence of these disorders? Intellectual disability has an overall general population prevalence of approximately 1%, and prevalence rates vary by age. Prevalence for severe intellectual disabilities is approximately 6 people per 1,000 people. Development course. How is the disorder developed? What is the development course it takes? Onset of intellectual disability is the developmental period. The age and characteristic features at onset depend on the etiology and severity of the brain dysfunction. Delayed motor, language, and social milestones may be identifiable within the first 2 years of life among those with more severe intellectual disability, while miles may not be identified until school age when difficulty with academic learning becomes apparent. All criteria, including C, must be fulfilled by history and current presentation. Some children under the age of 5 years whose presentation will eventually meet criteria for intellectual um, disability have deficits that meet criteria for the global developmental delay. When intellectual disability is associated with a genetic disorder, there may be a characteristic physical appearance, such as in Down syndrome. Some syndromes have a behavioral phenotype which refers to specific behaviors that are characteristic of particular genetic disorder. In acquired forms, the onset may be abrupt following an illness such as meningitis or head trauma occurring during the developmental period. Risk and prognostic factors. There are some that we will be reading. Genetic and physiological. Prenatal etiologies include genetic syndromes such as sequence variation or copy number variants involving one or more genes, chromosomal disorders, inborn errors of metabolism, brain malformations, maternal disease, including placental disease, and environmental influences such as alcohol, other drugs, toxins, um, teratogens. Perinatal causes include a variety of labor and delivery related events leading to neonatal encephalopathy. Postnatal causes include hypoxia, ischemic injury, traumatic brain injury, and infections. Culture related diagnostic issues. Intellectual disability occurs in all races and culture. Sensitivity and knowledge are needed during assessment, and the individual's ethnic, cultural, and linguistic background, available experiences, and adaptive functioning within his or her community and cultural setting must be taken into account. Gender related diagnostic issues. Overall, males are more likely than females to be diagnosed with both mild, with an average of male to female ratio of 1.6 to 1, and severe with an average of male to female ratio of 1.2 to 1 forms of intellectual disability. However, gender ratios are widely in reported studies. Sex-linked genetic factors and male vulnerability to brain insult many account for some of gender differences. Diagnostic markers. A comprehensive evaluation includes an assessment of intellectual capacity and adaptive functioning, identification of genetic and non genetic etiologies, evaluation for associated medical conditions, and evaluation for co occurring mental and emotional and behavioral disorders. Components of the evaluation may include basic pre and perinatal medical history, three generational family pedigree, physical examination, and genetic evaluation, and metabolic screening and neuroimaging assessment. Differential diagnosis. The diagnosis of intellectual disability should be made whenever criteria A, B, and C are met. A diagnosis of intellectual disability should not be assumed because of a particular genetic or medical condition. A genetic syndrome linked to intellectual disability should be noted as a co-current uh, diagnosis with the intellectual disability. Now we'll move on to the categorization of where the differential diagnosis can come in. Major and mild neurocognitive disorders. Intellectual disability is characterized as a neurodevelopmental disorder and is distinct from neurocognitive disorders, which are characterized by loss of cognitive functions. Major neurocognitive disorder may co-occur with intellectual disability. For example, an individual with Down syndrome who develops Alzheimer's disease, or an individual with intellectual disability who loses further cognitive capacity following a head injury. In such cases, the diagnosis of intellectual disability and neurocognitive disorder may both be given. Communication disorders and specific learning disorder. These neurodevelopmental disorders are specific to the communication and learning domain and do not show deficits in intellectual and adaptive behavior. They may co-occur with intellectual disability. Both diagnoses are made if full criteria are met for intellectual disability and a communication disorder or specific learning disorder. Autism, autism spectrum disorder. Intellectual disability is common among individuals with autism spectrum disorder. Assessment of intellectual ability may be complicated by social communication and behavior deficits inherent to autism spectrum disorder, which may interfere with understanding and complying with test procedures. Appropriate assessment of intellectual functioning in autism spectrum disorder is essential, with with um, reassessment across the developmental period, because IQ scores in autistic spectrum disorder may be unstable, especially in early childhood. Comorbidity. Comorbidity. What is it? It is basically when a disorder is present with another one. Comor- Co-occurring mental, neurodevelopmental, medical, and physical conditions are frequent in intellectual disability, with rates of some conditions, that is, mental disorders, cerebral palsy, and epilepsy, 3 to 4 times higher than in the general population. The prognosis and outcome of co-occurring diagnosis may be influenced by the presence of intellectual disability. Assessment procedures may require modifications because of associated disorders, including communication disorders, autism spectrum disorder, and motor sensory or other disorders. Relationship to other classifications. So basically, we have different terms that we use. ICD-11 in development at the time of this publication is the term, is the code for intellectual disability disorders, which actually indicate that there is an impaired brain functioning in life. They are described in one main heading, which is ICD-11. Global developmental delay. This diagnosis is reserved for individuals under the age of 5 when the clinical severity level cannot be reliably assessed during the early childhood. This category is diagnosed when an individual fails to meet expected developmental milestone in several areas of intellectual functioning, and applies to individuals who are unable to undergo systematic assessments of intellectual functioning, including children who are too young to participate in standardized testing. This category requires reassessment after a period of time. Unspecified intellectual disability. This category is reserved for individuals over the age of 5 years when the assessment of their degree of intellectual disability, intellectual developmental disorder by means of locally available procedures is rendered difficult or impossible because of associated sensory or physical impairments, as in blindness or prelingual deafness, locomotor disability, or presence of severe problem behaviors or co-occurring mental disorders. This category should only be used in exceptional circumstances and requires reassessment after a period of time. So, this was intellectual disability or intellectual developmental disorder in the major framework of neurodevelopmental disorder. So today I have given you an introduction of what neurodevelopmental disorders are, and in that we have covered one disorder in which is intellectual developmental disorder. So I will be seeing you hopefully in the next lecture where we will be continuing with communication disorders. So hopefully I'll see you soon.